Top Bed Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Bed Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
This piece is presented by Nick Fletcher, Chair of the Institute for Anaesthesia and Critical Care at the Cleveland Clinic, London, consultant in anaesthesia and critical care at St George's Hospital NHS Foundation Trust. Have a listen.
Thank you very much. Now, I'm afraid I don't have any great science to present to you today, but I may be able to answer a few questions because I think quite a few people have heard of the Cleveland Clinic setting up in London, and I'm not quite sure if people understand what's going on here. I invited Monty down to come and meet our CEO and have a chat about the project, and he very kindly invited me down here to talk about this. Now, in terms of doing this talk, I could really talk about anything because the Cleveland Clinic London doesn't actually open to inpatients till 2021. So I could basically tell you we're going to do all kinds of amazing things. But the whole point of the project is to take the vision of these guys who set the Cleveland Clinic up in Ohio nearly 100 years ago, 1921. And their vision was to put patients first. They had a number of different parts of this vision, but the overwhelming part of this was to put patients first and to put the patients at the centre of care. And I think that's something all healthcare systems attempt to do. The other ambition, realised really 100 years later, is to have a sort of a globally integrated healthcare system. Now, we understand what an integrated healthcare system is in the UK. We have the NHS. But the idea was to have hubs in North America, in Abu Dhabi, which is already open and functional, and then the latest one, Cleveland Clinic London. And to run along the same sort of principles, the same ethos, using the same technology. And technology is very important here. I'm going to say a little bit more about that as we go along. But I went to visit the Cleveland Clinic in April. We managed to land in Chicago in a blizzard and then had to travel overland, and with apologies to people who live there, there's not a great deal to see around the Great Lakes. It's sort of very flat, and particularly in the blizzard. But the visit was very impressive. The scale of the Cleveland Clinic, I think, is something that would be very impressive to all of us who work within the NHS, and the ambition. But interestingly, I know we think of sort of US healthcare corporations as sort of generating huge amounts of money and taking up lots of the GDP for healthcare. But actually, the Cleveland Clinic system is not for profit, and I was very impressed by this ethos. And apart from the sheer volume of people they employ and the number of hospital episodes, patient visits and patients treated, any surplus that's generated is put back into the services. So if you look at the Lerner Research Institute, it's a real sort of powerhouse of research, and I think Cleveland Clinic, particularly sort of outcomes research, is well known the world over. But they just opened this healthcare education campus, which I think any of us would be really jealous to look at these facilities. I mean, I think it was designed by Norman Foster, I think cost nearly £500 million. But they were just opening this, and it was a very sort of integrated for medics, nurses, and all the other specialities that we have around us. And you can see an impression there before it was open, but it was just open when we were there. So it's, in the same way, some of this resource is being put into the Cleveland Clinic London, and surplus is not going off to private equity and shareholders, which a lot is what happens generally in the independent sector in London, but any surplus will be put back into the healthcare. So the vision for London really was to carry on this idea of patients first, build a digitally integrated smart hospital. So basically there's a 7-floor new build hospital within the facade of a 1950s building, and we've gone down 2 floors, and there's the chance to really build something that's up to date and will last into the future. And also to integrate the best of the Cleveland Clinic vision with what we do so well in the UK. And I think we probably all agree, but particularly if we work in the UK, that I think we really punch above our weight in terms of the resources we're given, and we can see some of this from a lot of the presentations that have happened over the last 2 days here. But if you want to see where the hospital is, you can have quite a pleasant walk down from Hyde Park Corner, where in fact the old St George's Hospital is, down towards Victoria, and you can see, I don't know if I can show you, I don't have a laser there, but you can see where the cranes are. That's where the hospital site is, and you can see we've actually got some rather elderly neighbours if you look across there at Buckingham Palace. So, but I don't think they come to us. I think they all go somewhere else. This is us on the roof. Some of the clinical leadership on the roof, you see looking towards the palace and across to London. And I think access is actually very much going to be restricted, and certainly they're not keen on flying drones around to try and film the project because of the neighbours. So basically it's a surgical hospital, and yes, it sits within the independent sector. I mean, some people have said to me there was a bit of a row when President Trump was here recently and talking about US-UK trade deals and opening the NHS to cherry-picking by US healthcare industry. And it's very much not about that. It's not about poaching NHS patients. It's about trying to take the best ideas from the NHS and using them within the Cleveland Clinic, and also hopefully giving stuff back to the NHS in various different ways. So these are the surgical institutes. The leadership are clinician leaders, and they are from the US. Most of the actual clinical institute chairs are from the UK. It's still very difficult, as some of you may know, for US physicians to work in the UK. There's a lot of barriers. Come the 31st of October, there may be some changes around this, but people have been very surprised about how difficult it is to bring in US doctors. So here's some of the ideas we think which can clinically differentiate ourselves from other independent sector hospitals in London. It's a 185-bed hospital, so we'll have 30 beds, 30 ICU beds, and we'll also have a 24-hour resident consultant presence. And I think this is something really that the NHS has flirted with. It's an expensive model, but I think when you have a lot of critically ill patients and potentially deteriorating patients, and particularly with our trainee ratios nowadays, I think we're going to have to go to resident consultant a lot more across all our healthcare systems. So there'll be night and weekend staffing with consultants. We'll have e-pharmacy, so an electronic medical management program, also using smart pumps, which are programmed from the Epic system, which I'll talk about in a little bit. One of the key things also is the physician leadership, the digital aspects which I identified, but also outcomes transparency. It's very interesting reading the literature from the Cleveland Clinic in Ohio, particularly around cardiothoracic surgery, cardiothoracic anaesthesia, which is one of my main interests, because there's a very big quality accounts document which comes out every year. And I think they're very ahead of the game on this. The intention is to present data to all the important UK outcome databases, such things as ICNARC, and also to be involved as much as possible in any outcome research that we can engage in. Talk about healthcare informatics. This is something that I think there's a real intention to try and build in. So what I understand by this is taking evidence-based medicine, so the best evidence we currently have, and you've seen a lot of this over the last couple of days, tying this in with our technology to assist clinical decision-making, at the same time integrating an ethical dimension to this. So I didn't quite understand what this meant, and I was talking to one of the people who's charged with leading this digital sort of revolution, and they said, well, it's about leveraging technology for empathy. And I said, well, what does that mean? So basically, what it means is, and what the chief executive of the Cleveland Clinic's drive is, to remove computers from healthcare, to remove the interface between the clinician and the patient. So, for example, if you can take the computer out of the room and you can take the conversation and interaction that the clinician has with the patient, which is automatically recorded and put within the healthcare recording information system, and can be edited using AI, I think that's what they mean by this digital revolution. And I think that's the ambition, to take away that computer interface. And this is part of this sort of expanded digital strategy, which we're going to try and take over from the US to the UK. And within this is, in terms of perioperative applications, we can try and capture a lot of the data that patients record on their own digital devices. So, for example, your Apple phone, you can record all your steps, you can record a lot of healthcare information now. And it's trying to get that information to the perioperative physicians who are making the decisions about your management in the perioperative journey. So, a lot of these health records can now be integrated into the EPIC system, which is the system we're going to use. I think they're also using this in UCL, in GOS, and Addenbrooke's. I mean, we're a Cerner hospital in St George's, and there's a lot of problems, but certainly I can't get anything like that, this interface. So, for example, this is a fictional patient who's coming for a procedure. You can see there's best practice guidelines. There's whether the patient's been assessed for tobacco use within the last year. And you can get a whole load of information about the patient, which can be integrated with best practice and evidence from perioperative medicine to see whether things have been done and assessments and evaluations have been made as steps on that journey. That patient integration from their own digital devices can be accessed through here. So you can look at the step count a patient's been doing, for example, in the run-up to their procedure. So the intention is to be able to use this to try and improve that perioperative journey and to utilise that evidence we have. Another thing you can use EPIC for, and again, we're not using this in the real world yet, but this is my experience of it, and we can decide and manipulate how this can be used to some extent. But you can look at your own provider quality accounts, which is something, I mean, we do appraisals and we sort of try and dig up the information to prove that we're suitable to carry on as doctors for another year. But here you can present real-time online quality accounts. So, for example, you can look at your own mortality, you can look at the hospital stay, the length of stay of your own patients, and you can look at the efficiency of your anaesthesia and your perioperative pathway yourself. So here's a load of the things that we can use here. We can do virtual visits using EPIC, and we can also look at deteriorating patients using a Vital Scout program, which can take the early warning system observations and integrate them and display them on a screensaver, so you can look at a virtual hospital which will show you different colours for different types of alerts around deteriorating patients. I can see Lee poised there because I'm probably running over time. So I just want to say finally, the other thing we can do with designing pathways, and this is something we've already started, is to integrate our evidence, for example, around ERAS, and put ERAS in every single clinical pathway. So this is something I was involved in recently, the publication about enhanced recovery after cardiac surgery. So, for example, we are going to put this in our pathway for all our cardiac surgical patients. In a similar way, we've just designed the pathway for hip surgery patients, and we've taken this very nice enhanced recovery document, which was published, I think, by the Hospital for Special Surgery in New York last year. And there's a lot of ERAS pathways for all different kinds of surgery, and the intention is to embed them all in our pathways as we design them. So that's pretty much it. I think I've maybe generated more questions than I've provided answers. And again, we don't open for nearly another 2 years. But I think it's going to be quite a special project. I'm very excited to be involved. I'm still working almost full-time in the NHS as well. And I think the intention is really to try and work with the NHS. And I've talked to a lot of NHS consultants. And I know the Chief Executive has reached out a lot to the Department of Health to work out how they can integrate and help to benefit a lot of the work that's going on in this country. Certainly in terms of research and education and training. And potentially our ambition would be to try and create an environment where we could actually train clinicians who are in training systems within the UK in the future. So have a look at the website if you'd like to know a little bit more about the project. Certainly the build is quite interesting. And if you wanted to email me about anything you've seen here or about any future role you might be interested in, please do. Thank you very much.
Hi, it's Desiree Chappell here. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Most of our podcasts from Top Med Talk are either presentations from the EBPOM conference or they're interviews with people who attend the EBPOM conferences. Have you always wanted to attend an EBPOM conference, but you are unsure because of travel, accommodation, costs, whatever it may be? This year, are you planning to respect social distancing and avoid attending large social gatherings while minimizing travel? Do you want to attend one of the most important medical conferences of the year without having to leave your home? Go now to ebpom.org and discover EBPOM Live from London. Get all the latest and greatest information streamed live to your home, office, or bedroom as you attend the conference virtually. Submit your questions, network, and hear these talks before anyone else in the world. In light of the recent COVID-19 pandemic, attendance for this conference is at an all-time high. We only have some limited spaces available. Carbon-friendly conferencing is here. Be part of the most exciting development in medicine since the invention of the stethoscope. ebpom.org.